So the next question in this multiple choice question paper, question 11, 44-year-old gentleman is brought into the emergency department by ambulance with a short history of bright red perirectal bleeding. So here we have signs of lower GI bleeding, or it's signs of fresh bleeding per rectum, and hematemesis. Hematemesis, it is a bloody vomiting. So he is unwell with a tachycardia of 110 and blood pressure of 115/60 and seems quite anxious. So which of the following statement is false? So he's asking about false statement. Blood test for hemoglobin should be sent urgently. This is, I think, this is the right thing to do. So this is correct statement to check for hemoglobin because the patient has, so the patient might have upper GI bleeding, severe upper GI bleeding. So most likely the patient has severe upper GI bleeding with this bright red rectal bleeding and hematemesis. So this is a correct statement. Intravenous proton pump inhibitor, PPI, therapy is indicated in this patient. Yes, it's indicated because the most common cause of upper GI bleeding is erosive and ulcerative disease in the either gastric mucosa or in the duodenal mucosa. So it's gastric or duodenal ulcer. And proton pump inhibitor is one of the main treatment for this kind of pathology. So the patient has lost approximately 750 to 1500 of blood. This is correct statement. Why? Because the patient has normal blood pressure is normal and heart rate is 110. This heart rate 110 with normal blood pressure, because this patient has upper GI bleeding, and this upper GI bleeding will cause hypovolemic shock. It will cause hypovolemia. So this hypovolemia can be classified into 4 classes. We have class 1 and class 2 and class 3 and class 4. Class 1 and class 2, it is normotensive hypovolemia or normotensive shock. Class 3 and class 4, it is hypotensive shock. So this patient has normotensive shock. Normotensive shock, either it's class 1 or class 2. With heart rate 110, it's class 2. It's called the class 2. Class 2 hypovolemic shock, the heart rate usually between 100 to 120. This patient has 110. So this, and the blood loss in the class 1, it is, in the class 1 hypovolemic shock, it is less than 750. In the class 2, it is between 750 to 1500. In the class 3, it is 1500 to 2000, and in class 4, more than 2000. So this is correct statement. The patient should initially be resuscitated with a crystalloid solution. This is absolutely correct. In cases of hypovolemia, usually we are starting resuscitation with a crystalloid solution. Upper gastrointestinal source of bleeding is excluded if the nasogastric aspiration is negative. This is incorrect. The nasogastric aspiration of blood can suggest or can highly suspect the diagnosis of upper GI bleeding, but the negative nasogastric aspiration can't exclude the upper GI bleeding. So this statement is the wrong and the most likely answer. This is the right answer for this question. So question 12, 82-year-old gentleman attend your clinic with 4 days of progressive dysphagia and melena. So here we have progressive dysphagia and melena. He now can swallow only fluid. So on examination, he is cachectic, and his GB letter tells you he has microcytic anemia, OTD confirmed malignancy. Which of the following is not a risk factor for esophageal malignancy? Alcohol is a risk factor, male gender is a risk factor, Osler-Weber-Rendu syndrome, or the other name of this, it is hereditary hemorrhagic telangiectasia, HHT. This is not a risk factor for esophageal malignancy. It is a risk factor for lung malignancy, I think for prostate malignancy, but not for and breast. I think it's related to breast malignancy, but it's not a risk factor for esophageal malignancy. So he's asking about esophageal. Plummer-Vinson syndrome is a risk factor, absolutely right. Smoking is a risk factor, yes. Here, the risk factor for squamous cell carcinoma of the esophagus or for adenocarcinoma of the esophagus, underlying esophageal disease such as stricture or diverticula or achalasia. Smoking is a risk factor for squamous cell. Alcohol and hot liquid and black race also is a risk factor. Adenocarcinoma, Barrett esophagus is one of the most important risk factors for adenocarcinoma. Smoking as well is a risk factor. Obesity is a risk factor. Gastroesophageal reflux disease, and more common in white population. So here the most likely answer, it is C, the Osler-Weber-Rendu syndrome. So question number 13, 47-year-old female present to her GP with a 6 weeks history of pain in her right upper quadrant and epigastrium. So here pain in the right upper quadrant and epigastric area, which radiate to her back. These episodes usually start after eating, so it is postprandial, after eating of fatty meal or fatty food, and resides after a few hours. It's stay for a few hours and then it goes by itself. There is associated nausea, but no vomiting, so it's associated nausea. She has no alteration in bowel habit, and she denies dysphagia and does not have weight loss. BMI 32, so she is obese. She is obese. It's obesity stage 1, and she is afebrile. She is afebrile and has unremarkable abdominal exertion. So the most likely, based on this finding and the chief complaint of the patient and associated signs and symptoms, the most likely the patient has what is called biliary colic. This patient is getting biliary colic. So which of the following investigation the most likely to yield the correct diagnosis? Serum amylase measurement, this is wrong. We can do this if we are suspecting pancreatitis, but this is not a typical picture of acute pancreatitis. Liver function test, it's unlikely to make the diagnosis. Esophageal gastroduodenoscopy ODD is unlikely. Urine analysis is unlikely as well. The most I think the correct answer is ultrasound. So ultrasound of abdomen, this is the correct answer. Let's move on to question 14. 67-year-old gentleman is on holiday from the UK when he presents to the ED after feeling progressively unwell over the last few days. He has a history of rectal cancer. He had a history of rectal cancer, which was treated in Manchester with neoadjuvant chemotherapy and radiotherapy followed by abdominal perineal resection. He has a stoma in his left iliac fossa. So he had a stoma in the left iliac fossa, and he had midline laparotomy scar. He complains that his stoma has not acted in the 2 days. This is the complaint. And he has been unable to keep down any food or fluid in the last 24 hours. So he had element of bowel obstruction. He had an element of bowel obstruction and inactive stoma. He has also been experiencing severe crampy abdominal pain. This is also associated with mechanical bowel obstruction. So he has dry mucous membrane. Which of the following is a sign of dehydration? He's asking about dehydration here. Bipasal crepitation. Bipasal crepitation, usually it can be seen with pneumonia, with lung infection, or sometimes with pulmonary edema. So this is a sign of fluid overload and pulmonary edema. So this is wrong. Bradycardia, that's wrong. Usually it's tachycardia is a sign of dehydration, not a bradycardia. Capillary refill time of 2 seconds. This is normal capillary refill line. It's not a sign of dehydration. So this is wrong as well. Oliguria, this is right. This is right thing. This is the correct answer. Oliguria, decrease urine output. Sacral edema, also it's wrong. Usually sacral edema seen in patients with fluid overload and hypervolemia. rather than dehydration and hypovolemia. So the correct answer here, I think it's oliguria, decrease urine output. So question 15, 56-year-old man attends his GP with 6-week history of retrosternal chest pain. He describes the pain as a burning in nature. It is not exertional. It occurs after eating and when lying down, and is relieved by taking Gaviscon, which is antacid. So this is the scenario is very typical for gastroesophageal reflux disease, gastroesophageal reflux disease. So the pain does not radiate and there is no associated dysphagia or weight loss. Which medication would you consider for this patient? Antispasmodic or calcium channel blocker or non-steroidal anti-inflammatory or probiotic or proton pump inhibitor? It is a proton pump inhibitor, which is anti-secretory medication that will decrease the secretion of the gastric acid to prevent this gastroesophageal reflux disease. So the most appropriate, it is the proton pump inhibitor. So the next question, I gonna discuss this in the next coming video. Thank you very much.